Thank you very much, and thank you for the invitation to come to Norway and Oslo again. I've been here before, and I love Norway. But I will start because we are, I guess, very late, and it's already evening. So I'm going to talk about our experiences in Finland and what we call the Effective Family Program. It is a program, but it's become a movement. It's not a program anymore. And here's our team. And I've been asked to point out some things that are important for implementation. And here's one. We are funded by national organizations which have responsibility over the country, which means that we have responsibility to take this work across the country. And so what we want to do is to break the intergenerational cycle of mental illness, drug abuse, and social marginalization by providing evidence-based methods, implementing them in health and social services. And we decided to start this work in adult psychiatry. And this was for several reasons, but maybe the most important was that when a parent first seeks for help, a patient comes in to the psychiatric clinic or health ward or whatever, this person who meets the parent is the first one to know that there's problem with the parent and mental illness in the parent in the family. And if we wait until the child services get alerted, then the children will have problems, because child psychiatry, school counseling gets active when children start having problems. And then the primary prevention is already, the opportunity for primary prevention is lost. And so the people in adult psychiatry are in a position to start the preventive work and to initiate the breaking down of the intergenerational cycle. And the next question for us was, who will do it? Which professional group? Is it the work of social workers? We usually think that the family things are for social workers. Is it for psychologists, doctors, nurses? And we decided that everyone who works with patients has to be able to talk about children in a constructive and respectful way. And this has some implications for methods. You have to have a variety of methods that people from different educational backgrounds can do it in different settings. And here are the methods that we have developed over the years. Let's Talk About Children is a simple discussion with your patient about children. Family intervention is something that you probably know all about. It's a more intensive method. We have parent groups in inpatient units in psychiatric hospitals, not all of them, but they have been started. Parent and child peer groups and family training and a network meeting. I will talk about a little bit more about that, and the guidebooks. And this is a developing field. We expect to have more methods with experience and with expansion of the work. This is a method family, which means that they all share certain principles. Not all methods are accepted in our method family. And this is what should happen when these methods are used. There's validation of everyone's experience. The parents' experience, my misery, my desperation about my children, or whatever, and the children's experience, my fears, what will happen to my family, what will happen to me, what's wrong with my parent. And with the intervention, with professional knowledge and interaction with the clinician, develops understanding of myself, my experiences, and the experiences of others in my family. What I call mutual understanding. And open communication, which makes parents and children closer together, supports the relationship, and also opens up an avenue for problem solving. If you can't talk about problems, then you cannot solve them. And so this is the kind of the process in very simple terms. And again, this also has a wolf trap for services. In Finland, it has become quite clear across the field that children should know what their parents' problems are. And a shortcut is that the clinician, a psychiatrist, psychologist, social worker, nurse, takes the child into the office and tells that your mother has depression and it's or schizophrenia or is suicidal, and then the child walks home. And this is not protective for the children. This can be destructive. Information and knowledge in itself is not what the children need. The information has to grow into understanding, and which feeds the relationship. So, that method that doctor just tells the children what the parents have, that doesn't belong to our method family. So let's talk about children. It's the simplest method, and what we think is that this is something that has to happen with every patient in adult psychiatry with children. And it's designed for practitioners who have no training in child development or in talking with children or talking about children with the parent. And you talk with the parent about the children and you make a promotive assessment. It's different from a child psychiatric assessment, which is basically about problems. You need a symptom profile and an understanding of the symptoms to be able to treat, to focus your treatment. But this is about prevention and promotion. So what we do is we make a promotive assessment with the parent for the parent to know what my child's strengths are, so that I can support them even further, and what my children's vulnerabilities are, so that I can help my children in this. Either I can do it within the home environment, or search for other services outside the family, or lean on the social network that I have. Grandmother, aunt, my friends, children's friends, and so on. And one of the key issues here in the Let's Talk About Children method is that how we define strength. Strength in a child or in the family is not some great achievement or some special talents. But if the family life or parts of family life and children's lives go on as they used to go, that's a strength. If the child manages school as he or she used to before the parent was ill, that's clearly a strength in a situation where a parent is mentally ill and probably cannot support the child in the school. And this has been very important for the families to realize that because parents have a feeling that they barely manage, that I'm not a good parent, I have all these problems. But when you point out that, my gosh, you take your child every morning to the daycare center, many mothers in this position where you have don't have the energy to do that, but you do it. And then I'm like, gosh, I never thought that this is a strength. And she feels more, well, if you want to use the word empowered, but better about herself, and it gives her strength to continue, and also to the child in different aspects of life. Okay, then we go back to the implementation again. When we take these methods to adult psychiatry, then the practitioners ask, how do I know if when a child needs psychiatric assessment or care? I have no training in this. How should I know this? And if I talk about kids or if I see them, I become responsible for recognizing their needs. And of course, people at least in Finland in adult psychiatry, have no training in this. And we say, don't worry, you don't have to be an expert, because you can get together, you can invite into your office or whatever meeting room you have, you can invite the people that you need. You can invite the family's own network if you want to activate the network to support the family. If you don't know whether this child has some psychiatric problems or not, you invite the child guidance clinic or whatever child psychiatric, adolescent psychiatric person in, and then you discuss, and that person decides. And then those people take the children by the hand, and the assessment and the treatment follows. So we don't expect adult psychiatry to be experts in assessing children or in treatment. Then the next argument is adult psychiatry is treatment of patients. We don't have to, children are not our job. We treat patients. And what then this work really does is that it puts a question mark behind that definition. Really, is psychiatric care only the treatment of the patient? How about the family? Or is it only treatment of the patient? How about promotion and prevention? And so actually we challenge the whole definition here. And what the whole issue is about is a paradigm change in the service system. From treatment to promotion and prevention, individuals, families, problems, strengths. So it's a big change. And let's see how we have managed it in Finland. Expansion of the effective family training. FTI is up there. It's family talk intervention. It's the family intervention, and LT is let's talk. It's a small discussion with a parent about children. In January 2004, we had the pioneering group, graduated 43 people, and now in November we have 700 people fully trained in both interventions. 23 trainers out of the 43 clinicians were ready to start work at 2004, and now we have about 70 trainers across the country. Finland has 21 health districts, and right now we have trained people in all of the health districts. This does not mean that every clinic, everyone does these methods all the time. This only means that in every health district we have people who have been trained, so that we have the kind of foot in the door. And the same thing is, there's trainers, health districts with trainers, so that 2/3 of the health districts have their own trainers, so they don't have to pay for training, they can use their own trainers. And then very many clinics have trained all their staff in the small intervention. Then let's talk about children. And the work has expanded. It started with adult psychiatry. All the time we have had people from drug and alcohol services to be trained along with the rest of the groups. But that last year or last winter we had our first focused training group, 20 people from drug and alcohol abuse services, doing being trained and doing systematically interventions. And so we got experience in both training them and practices, and they said that this work is a revolution in their approach with their families, and they're going to have trainers themselves now. It's been taken to somatic illnesses. In some cancer clinics have systematically trained their staff. Other hard to talk about problems in the families. Child protection services, social services, child psychiatric services take care, and so on. So then I wanted to take up some points about why this success, because we think that at least now it's been a success. First, there was and there is an unmet worry about children in the psychiatric care system. I was told first when I started this work that don't go to adult psychiatry. They're not interested in children, and that's exactly the opposite. This program started as a one-woman effort. When I first wrote my application to the ministry, I had no team. I just had the idea that this has to happen. And when I first thought that it would be good if I get 10 people from around Helsinki interested in this, and that would be a good initial group. And when I started asking the clinics around Helsinki, the adult psychiatric clinics, all of them, just about all of them, not two said that one said that they were busy with other things, and one head doctor said that children aren't our business, so I didn't bother them more. But the rest of them said, yes, we want to be there. And then the word, without me, the word got around Finland about this. And clinics almost up to Lapland wanted to join. So that the first group was 27 or 8 people. And then within half a year, so many people insisted that please include us all, so that the pioneer group, after all, was 45 people. So this all came from the adult psychiatric world. Then some issues of training. Keep your goals clear. Do you want to teach a method, which means that you just want to add something into the old tool pack? Or do you want to change the system? And the training is different in relation to whatever your answer is. And of course our answer in Finland, because we didn't have this work at all, and adult psychiatric clinics didn't have anything to do with kids, we wanted to change the system. Which means that in the training, we had to be much, I trained people in the history of this work, in the development, in research, and about theories, and so on, along with the method. So that actually the individuals moved from learning, or while they were learning the method, they also learned a new way of working, understanding and conceptualizing their work. And the same goes for organizations. So you have to work on all levels at the same time. You can just not, in the initial phase when the work is new, you cannot just be happy with training the method only. So that the pioneering trainees became trainers and agents of change in their own localities across Finland. And so when the training was finished, they spread around Finland, and we have a lot of centers of development for this work. And they have trained their surroundings and their people, and that's why we have 700 people who've been trained in a few years in both of the interventions. Okay, then the methods have to be something that are okay as well. If you cannot implement anything. We have a randomized controlled trial between the Let's Talk About and the family intervention. And we have 119 families randomized into these two groups. And some of the data that I will show you is answers to these kind of questions. The first thing you have to make sure of is that your methods are safe. And the most important thing that people in adult psychiatry want to know is that, is my patient safe? What do these methods do to my patient? They're mentally ill, they might be depressed. 2 minutes? Wow. I've been talking too much. Okay. Let's see. So what we found out that was that you can look at the positive change, one's own well-being, and you can see that the families started to feel better, the parents, and their treatment motivation went up. Oh, wait. And also 72% of the children reported that they felt better after the intervention. Then we wanted to know something about the kids. Did this work increase their worries? Because this is something that we shouldn't do. That's what the parents are often very worried about. No, we didn't. Was there any harm done? Mostly not. There were a couple of parents who said that yes, and the child said that I didn't know what to answer in the question when I was questioned. But now I have to jump a bit. But maybe these are so interesting. But what we want to increase mutual understanding, and so the parents report 81% in the family intervention, and in the small intervention, half of the parents say that I understand my children better. And the children report that my parent understands me better, and I understand my parent better. And how do the children feel about having been interviewed with this adult psychiatric worker who has no training in children? And we can see that children felt comfortable with the practitioners in adult psychiatry, and so we think that adult psychiatric practitioners can do the job. The parent's sense of self. Accepting oneself and feelings of guilt and shame. The issues of stigma. Do we increase stigma when we talk about difficult things? And you can see that there's a lot of positive change here. Let's Talk is in this slide, and here we have the family intervention.
1 minute.
Okay, 1 minute left. The methods undo stigma. And I think that is something very important and powerful, and maybe explains the next results partly. We studied the clinicians in the pioneering training group and asked about their joy at work and work motivation. And you can see that adult psychiatric practitioners, when they started to talk about kids with their patients, it increased their work motivation and gave them joy. And I think the fourth success point is that this work links us with the great goals of the humankind: to undo the stigma of mental illness, increase respect and equality among people. Because I think these are actually the motivating forces behind our work in general.